I'm gonna set up the live stream.
Exciting.
We are live.
All right. I'm going to put the captioning link inside the Facebook.
Thank you.
And then, Sean, if you, because I did write out my own message and it worked, but I think you have a message about watching it on Facebook. Can you throw that in the chat?
Oh,
too?
yeah, absolutely.
Thank you.
There we go.
Hooray. Muchos gracias.
Put that out, this one out there too.
Saving it to everything I can.
One last one.
Yay.
Nice.
Thank you. How was your class?
It was good. Yeah, students are awesome. So I got a very intimate story about some roommate nightmares for the past week. And someone's moving out and therefore their assignments are late. And I was just like, no problem. That's, you do life and then just give me the content and do a good job. That's all that matters.
What class is it?
Ethics and disability.
Okay. That sounds cool.
It is cool. It's lots of fun. It kind of covers a lot of bases. So we get to just kind of dig into the pressing issues around disability.
Hey, John, we also had a request or an email about that particular topic around
Oh, really?
ethics and disabilities.
Oh, wow.
So maybe that's something we can consider for 2023 around ethics and disabilities.
Yeah, I'll be, I think, 2 classes in at that point. I should be able to just
Okay.
do it off the top of my head.
And I think we did do one around, I think, no, maybe a staff meeting on ethics and representing people with disabilities. So I think that's something to put down for possible next year, ethics and disabilities.
It'd be a great topic. Lots
Yes.
of great conversation.
Yes. So I'm making a note of it for next year.
Do they call you Mr. McDermott?
I get that and hi professor in emails.
Wow.
Yeah, totally.
Wow. Now that's fancy.
It is fancy. I'm just kind of like, oh, I wish they only knew me. And then they would call it.
Being respectful.
It's amazing. I can't stop thinking about them. That's the thing I've taken away from this is that I go home and I think about them, and I wake up in the morning. I'm like, oh, I like to talk to the student, and
That's cool.
Awesome.
yeah, teachers should be paid about triple what they're being paid right now, and I think we'd have the best education system in the world if that was the case.
Yeah. All right.
12:59, friends.
Yeah. I'm gonna start admitting all and then I'll close the waiting room. We all ready though? Before I do that?
Sounds good.
I'm ready.
I think we're good.
Okay. Here they come. Hello, everybody. Welcome. Now is a great time to check your audio and video settings. We will get started in just a moment. All right, let's get started. My name is Jeff Javier, and I'm with the University of Arizona Sonoran Center for Excellence in Disabilities. I'm just going to go over a few community guidelines before we get started. Number one, assume good faith from your colleagues. We are all here to learn together. Number two, please use the chat or raise hand function if you wish to share. Participants are not permitted to unmute themselves. To share verbally, you will be called on after virtually raising your hand. Three, please recognize and respect others' feelings, background, and cultural differences. Four, not all questions will be answered during this meeting. Five, be judicious and efficient with shared information and experiences. If you are speaking, try to limit yourself to 30 seconds or less. It can be just as courageous to listen as it is to share. So please do your best to understand when it is best to step back instead of stepping up. If you are speaking, please speak slowly as we have an English captioner and ASL interpreters working diligently. This is true for meeting presenters as well as participants. For the lawyers in the meeting today, we do have CLEs, and more information about that will be coming up. And we also do have certificates of attendance, and that will be part of a survey that will come at the end for everyone to fill out. So two different things. For lawyers, CLEs, more information 3/4 of the way through the meeting today. And then the certificate of attendance. At the end, you finish a survey. All right, I will now hand it off to Natalie Luna Rose.
Thank you, Jeff. Hi, everyone. I am Natalie Luna Rose. I'm the Outreach and Communications Manager for the Arizona Center for Disability Law. Welcome to the 6th session of the 11th Annual African American Conference on Disabilities, our 2nd year doing it virtually. So I want to thank you for joining us this afternoon. I see in the chat that it's pretty busy. People putting in where they're from. Thank you so much. And if this is your first time with us, if you wouldn't mind letting us know where you're located, as we're keeping track, as we've had people as far away as New Zealand, Nairobi, Germany, and other places attend the conference already. So thank you for that. And before I introduce today's speakers, I would like to thank our sponsors for without their support, we could not put on this amazing conference. So thank you to our gold sponsor, Perkins Coie, our silver sponsors, Arizona Department of Health Services, Children and Youth with Special Healthcare Needs, Valley Toyota Dealers, our bronze sponsor, Ability 360, and our advocate sponsors, Arizona Statewide Independent Living Council, Arizona State University, Arizona Developmental Disabilities Planning Council, Arizona Commission for the Deaf and Hard of Hearing, Arizona Community Foundation, Banner University Health Plans, Diverse Ability Incorporated, Lexus Superstition Springs, National Disability Rights Network, Marks the Spot Barbershop, NAACP Maricopa County Branch, Raising Special Kids, and Unique's Multicultural Connections. And also thanks to our co-hosts, the University of Arizona Sonoran Center for Excellence in Disabilities, Northern Arizona University Institute for Human Development, Arizona Center for African American Resources, ASGAR, and my colleagues here at the Arizona Center for Disability Law. Again, thank you so much for your support for this conference. So today's session, as I said previously, we are in our 6th session, and today's title is Legal Rights and Best Practices for Individuals Experiencing a Mental Health Crisis. My colleague, Asim Dietrich, will be one of the presenters, as well as Doral Hill, Policy Director for ACLU. And Asim, I will pass that on to you.
Thank you, Natalie, and good afternoon, everyone. I have a PowerPoint for today's presentation, so I'm just going to share my screen. Okay, so today we're going to be discussing the legal rights and best practices for individuals experiencing a mental health crisis. And I'm Asim Dietrich. I'm a supervisory attorney here at the Arizona Center for Disability Law, and I've been here about 10 and a half years. And so the learning objectives for today will be issues with the current crisis response model, legal rights under the Americans with Disabilities Act for individuals who need mental health crisis services, legal obligations under the ADA for law enforcement, as well as other crisis service providers, and some best practices and ideas for reforming the crisis response system. So, and if anyone has questions during the presentation, I'd be happy to answer any questions that come up during the presentation. So first, the first part is talking about law enforcement and mental illness. So I'm going to just share some statistics from a research paper that was published in 2015 titled Overlooked in the Undercounted by the Treatment Advocacy Center. And I have a link there to the research paper if anyone is interested in reviewing it. So according to the paper I just mentioned, persons with severe mental illness or SMI are about 4% of the US population. However, nationally, 1 in 10 of all law enforcement responses are for persons with SMI. So usually for persons with SMI or serious mental illness who are in a mental health crisis. And persons with SMI are 1 in 5 of all incarcerated individuals. So individuals incarcerated in jails and prisons, 1 out of 5 of those individuals have a severe mental illness. And persons with SMI also make up 1 in 4 fatal encounters with law enforcement. So even though people with severe mental illness are 4% of the population, they make up about 25% of fatal encounters with law enforcement. And again, most of these individuals are people who are experiencing a mental health crisis. So given that last statistic, persons with untreated SMI are about 16 times more likely to be killed in a police incident than persons with mental illness, and than persons without mental illness. So what that really shows is that people with mental illness often experience a mental health crisis due to a lack of treatment or inadequate treatment. So they're much more likely to be caught up within the criminal justice system, and also much more likely to be killed in a police encounter. So, and the reason this is such an important issue is because the first contact for many persons with mental health crisis is often law enforcement. Many states and or cities may not have a designated mental health crisis line. So you know, for many people, the only option when they or a family member are in a mental health crisis is to call 911. because their state or other jurisdiction where they live does not have a separate mental health crisis line. And even in jurisdictions where a crisis line or mobile crisis services are available, persons with mental illness are often not informed how to access these services. So, for example, Arizona does have a crisis line. Arizona has 3 crisis lines depending on the region of the state in which an individual lives. But many people are still not informed that this crisis line even exists. And police officers, as we most likely have seen, police officers are often untrained in mental health crisis intervention. So it's really not what police officers and law enforcement are trained to do. Mental health crisis really should be handled by mental health professionals. And the police response, as we've also seen all too often, is often focused on compliance and not assisting the individual in obtaining crisis services. So when law enforcement is dispatched to a scene, often they're not arriving at the scene with the intention of providing crisis services. They're arriving to make sure that everyone is safe. So their main focus often is on compliance and complying with police orders, rather than ensuring that the individual receives the crisis services they need. So now I'm just going to discuss the current crisis response system within Arizona. And Arizona is an example of other states that do have a crisis response system. So Arizona does have a crisis-run response, a state-run crisis response system.
Asim,
Yes.
sorry, we have a question in the chat.
Okay.
The question is there data that shows whether or not states with a crisis line have lower incidences of police involvement or fatalities?
I'm not aware of any data that shows that. It may be available. I just haven't seen it. And even the data, one of the major issues is that even the data around police incidents where individuals are either injured or die during a police incident, even that data is incomplete because many departments don't actually keep track of that. So various newspapers, media organizations, social scientists try to keep track of that information. So the data itself is incomplete, and that's also one of the issues. So even though Arizona has a state-run crisis response system, a lot of what Arizona does, it may be an example of what not to do. At least we have a system, but our system still has some major issues. So the northern, southern, and central Arizona regions all have separate dedicated crisis lines. So these are 10-digit phone numbers an individual can call if they're experiencing a mental health crisis or their family member is. But there's not enough of an effort to inform the general public of these crisis lines. So really the people who are informed of the crisis lines are individuals who are already receiving services within the state-funded behavioral health system. So if individuals are not yet within the system, oftentimes they're unaware of these crisis lines, and so their only option is to call 911. And even when an individual is able to call the crisis line has access to the crisis phone number and is able to call. Crisis line staff are often unequipped or undertrained to adequately respond to a mental health crisis. So even the staff at the crisis line often don't have the necessary training to assist with a mental health crisis. So inadequate training for responding to individuals with co-occurring intellectual or developmental disabilities and mental illness is also an issue. So if someone has an intellectual or developmental disability and are also experiencing mental health crisis, most crisis line staff are not trained to assist such an individual. And some examples may be individuals who are nonverbal, who are in a mental health crisis. And what we've heard from the community is often when they will call for the family member who may be nonverbal, what they hear from crisis line is that individuals who are nonverbal cannot benefit from mental health therapies, which is clearly inaccurate. So that inadequate training is a major issue even for crisis line staff. And if the crisis cannot be dealt with over the phone, Arizona has mobile crisis available, but with some very important caveats. So just for some background, mobile crisis service is basically a service that's provided where mobile crisis providers can actually go to the scene of a mental health crisis. So an individual would call crisis line. If the crisis line is unable to assist, they can then request a mobile crisis team to come out to their location to assist them in person with their crisis. So, the intention of the service is very good. It's a necessary service that I think all states should have, but the way it's been implemented, again, has some major issues. So, Arizona regulations allow the mobile crisis providers to respond within 60 to 90 minutes after after being dispatched, depending on the location of a mental health crisis. So in urban areas, the time limit is 60 minutes. In rural areas, it's 90 minutes. So even the policy set by the state, the regulations set by the state allow too much time to elapse between the time someone requests mobile crisis and the time that they actually receive assistance. Waiting that amount of time for someone in a mental health crisis can often lead to tragic results, because these could be individuals who are either a danger to themselves or others and need immediate assistance with their crisis. And mobile crisis providers themselves are often inadequately trained to deal with mental health crises. So oftentimes, and we've heard this again from members in the community through our work, is the suggested solution often is simply to go to the emergency room. So these mobile crisis providers themselves don't often have any other solution than simply the emergency room. And persons in crisis are often resistant to treatment as well. So in any case, even if mobile crisis does come out to the scene to try to assist the individual, if the individual is resisting treatment, the mobile crisis provider may call the police to have the person transported to a psychiatric facility. So even after the crisis line is unable to help, an individual is waiting for a long time for mobile crisis to come out to their location. Even after all of that happens, law enforcement may still have to get involved to transport the person to a psychiatric facility. So, and just some some real life stories that again that the Center for Disability Law has encountered through some of our work and contact with some of our consumers and clients. So this is a story about a mother and an 11-year-old and her 11-year-old son who live in rural Arizona. So the son has autism as well as multiple psychiatric diagnoses. So the mother often calls the mobile crisis team when the son becomes a danger to himself or others. Unfortunately, the response time for the crisis team has typically been about 2 hours. So even longer than that 90-minute time limit provided by regulation. And by the time the mobile crisis team arrives, the son is calmed down and the crisis team says that no intervention is needed. But while they were waiting that 2 hours for the crisis team to arrive, the son may destroy property and pose a danger to his mother. So the mother has actually stopped calling crisis because they are unhelpful. So because now this mother no longer trusts crisis to actually assist her son, she may be more likely to call 911, which means her son may be more likely to have involvement with the criminal justice system. So another story that I can share with you is, so fearing for her life and not knowing where else to call, a non-English speaking mother called the police because her son was in crisis. So he is nonverbal and has autism, and this was the 9th time she's called the police in the span of 8 months. Each time the situation has escalated further, resulting in her son attacking the police during this latest incident. Prior to this call, her son has been denied behavioral health services due to his behavior. So in this situation, the existing community-based behavioral health system is not assisting this individual who has autism as well as mental health diagnoses. He's unable to receive services, and the mother doesn't speak English, so she's unable to access the crisis line. So the police are the only option. And in this situation, the son is lucky that something tragic didn't occur because he did attack the police in his previous crisis. So again, this individual is in danger because the only response they have is the police. And if this aggressive behavior gets too far at some point, there's no telling what might happen with the police being present. And then just another story I'd like to share. So a parent received a court order to place her adult son who was suicidal, has schizophrenia, and autism in a level 1 treatment facility. So a court order in Arizona, we have an involuntary commitment system where individuals who are resistant to psychiatric treatment can be ordered by a court to either receive mental health services in the community or be committed to a facility. And a level 1 treatment facility in Arizona is a locked psychiatric facility. So it's the most restricted setting to receive psychiatric services. So the mother in this case, the parent in this case, called crisis services to get the services her son needed and to fulfill the court order. So again, the request was that mobile crisis come out and transport her son to the facility where he needs to be committed to fulfill the court order for treatment. Now However, crisis services simply called the police to transport her son, but they didn't send anyone from crisis services to help. So no mental health professionals were on the scene. It was just the police. And the police didn't do anything because the son, the individual, was inside his own home and not committing a crime. So a court had determined he was gravely disabled, a danger to himself and others, and needed to be in a psychiatric facility. But the police would not enter the home to transport him to the facility because he wasn't committing a crime. And crisis service was not on the scene to assist in getting him from the home to the facility. So the mother was told to go home, and she didn't know where else to turn and was fearful for her son's safety. So we don't know ultimately how that situation was resolved, but we do know that this individual's mother called crisis. Crisis was not any help, and then the police arrived at the scene, and the police were not any help. So the entire system was unwilling, even though there was a court order that this individual received treatment. The entire system was completely unhelpful for making sure that the individual complies with that court order. So the next section I'd like to discuss is some of the disparities between people with maybe in the physical health crisis and individuals in the mental health crisis. And again, if there's any questions about what we've discussed so far or this next section, please feel free to either chime in or put a question in the chat. So just as an example, a person in a physical health crisis can call 911. So if an individual is having a heart attack or they've been in a car accident or some other type of injury or medical emergency, they call 911. An ambulance usually arrives within 3 to 5 minutes, and the individual will be safely transported to a local hospital for treatment. However, and then you compare that to an individual in a mental health crisis. So again, the police are often called in a mental health crisis. The person may be, so the individual may be subject to arrest, incarceration, or police violence. If mental health crisis services are available, the crisis line is inadequately trained to verbally de-escalate a crisis. Even if mobile crisis is available, it is a fight to convince them to come to the scene of the crisis. So even getting a mobile team dispatched is a fight in itself. If the mobile crisis team does agree to assist, there's an hours-long wait for mobile crisis to arrive, and they often call the police after all of that. So just think about the disparity here. An individual in a medical emergency gets treatment very quickly in a relatively short period of time without being worried about being arrested, injured, or killed by the police. And again, it's probably the emergency services arrive within minutes. For a person in a mental health crisis, it's a completely different situation. So based simply on the presence of that mental illness, these individuals are receiving subpar emergency services simply because it's a mental health crisis and not a physical health crisis. So that's just an explanation of some of the disparities we see between people with mental health crises and physical crises. So now I'd like to move on to a discussion about some of the legal rights and legal obligations under the Americans with Disabilities Act, and how that can extend to crisis services. So the ADA requires, this is Title II of the ADA, requires no qualified individual with a disability shall, by reason of such disability, be excluded from participation in or be denied the benefits of the services, programs, or activities of a public entity or be subjected to discrimination by any such entity. So basically what that means in layman's terms is the persons with a public entity cannot discriminate against a person because of their disability. In addition to not being able to discriminate, public entities have to make sure that people with disabilities are able to participate in or get the benefits of any service or program of that public entity. So it's a very broad prohibition against disability-based discrimination. And public entities are defined as any state or local government department, agency, or instrumentality of a state or local government. So that definition basically extends to anything a public entity does. So basically any function, any service, program, or activity of a state or local government is considered to be a public entity.
Asim, we have a question in the chat.
Yes.
Yeah. Is there any evidence that mobile crisis teams may be deliberately delaying the response at the scene because they're wanting to avoid endangering themselves, hoping the crisis will naturally de-escalate? I imagine that evidence would be difficult to obtain if that does occur.
So yeah, I haven't seen any data that supports that or doesn't support that. What I will say is that mobile crisis, at least in Arizona, does seem to be underfunded. So there may be a situation where there just aren't enough mobile crisis teams available. But as far as whether it's a danger, mobile crisis services are only available if it is if the individual is unarmed, if there isn't a weapon present. So if there is a weapon present, mobile crisis would transfer that call to the police. But if there is not a weapon present, then mobile crisis should be the ones to respond. So there could be individuals who pose a danger to themselves or others based simply on their behaviors, but do not possess a weapon. And those individuals can, often those situations can be de-escalated through verbal means. So that is the only time really mobile crisis would be called. So if there's a weapon present, that would always be for law enforcement. So just the definition for people with disabilities under the Americans with Disabilities Act. So a qualified individual with a disability is a person with a physical or mental impairment that substantially limits at least one major life activity and is qualified for a service or program of a public entity. So persons with mental illness have a disability because they have a mental impairment that substantially limits major life activities such as thinking, concentrating, communicating, those types of activities. And people with mental illness in a crisis are qualified to receive emergency crisis response services.
Asim, we have another question.
Okay.
This is from Isabel. She asks, I've heard about the rollout this July of 988, a mental health crisis line, which advocates hope will take place 911 for, it will take the place of 911 for mental health emergency services. She doesn't know much about 988, but what do you think of this program? Do you anticipate any problems with its rollout?
Well, so my understanding of 988 is that it's actually a replacement for the National Suicide Prevention Lifeline. So instead of having that 10-digit number, an individual anywhere in the country would call 988 and be connected with suicide prevention services. So there's actually no guarantee that 988 would actually connect people with crisis services if they're not suicidal. So that's one limitation that 988 is likely to have in many areas of the country. The other issue is that our existing crisis service system is underfunded and under-equipped to handle the number of mental health crises that they see every day. So having 988, having a 3-digit number now that is widely available nationwide will stretch that system even more. So our concern as advocates is that 988, while the intentions are good and while it's an important step forward, it will not make much of a difference until crisis service systems themselves are funded adequately. And that's the best way of getting the best staff and the most trained staff, the most qualified behavioral health professionals, is to make sure the system is funded. So without adequate funding, you're going to have a system that's already stretched thin, needing to handle so many more calls under 988. So the most important issue here is funding and training, making sure there's enough funding to hire qualified staff, and then making sure they have adequate training to assist with crisis response.
We have another question. How could we go about making sure there are teams to address crises with individuals who also have developmental disabilities?
Well, again, I think it is a question of really training and having the money to hire the most qualified people, and then giving the necessary training to assist people with co-occurring disabilities that may have an intellectual developmental disability as well as a psychiatric disability. So really that's the bottom line is, taking law enforcement out of crisis response and then making sure the civilian aspect of crisis response is adequately funded and that staff is adequately trained. And ACDR actually signed on to a report regarding this particular issue, regarding the inadequacy of crisis response for people with dual or multiple diagnoses. So it definitely is an important issue that we're aware of, and I think it can be solved with additional funding, but also adequate monitoring, making sure that the crisis system is monitored by the state and by state funders, making sure there's adequate response post-crisis, making sure that someone's insurance plan and their healthcare providers are informed when that individual has made a call to the crisis line, making sure there's that communication to make sure the individual can get the care they need after the crisis. And then also adequately funding the behavioral health system to prevent individuals from going into crisis, making sure that individuals get the services they need before they ever get to that point where they're in a crisis. So I think all of those things are important, and also simply just educating people about developmental disabilities and intellectual disabilities, and really informing crisis staff that someone with those disabilities can also have a mental health crisis. They have the same capacity as anyone else to be in mental health crisis, and need the same assistance as anyone else, oftentimes more assistance.
We got one more. Does any city or state have a commendable mobile mental health crisis response that should be emulated?
I will talk later in the presentation about some ideas for reforms, as well as some states who are doing a better job than Arizona. The issue is that I think in this in the United States that no state is doing as well they should be doing. Certain states do better than others. Some examples I'm going to share are Connecticut and Oregon. They do a little bit better job, but I wouldn't say there's any state currently has a model that should be followed. I think there's certain best practices that need to be more fully implemented, that just haven't been implemented nationwide. Okay, so thank you all for your questions. So moving forward with the slides. So this is just some information about what is considered discrimination under the ADA. So discrimination includes providing an unequal benefit or service when compared to people without disabilities. So again, if we compare the response to physical crises versus mental health crises, we can see there's an unequal benefit there in the emergency response system based upon different disabilities. Providing a benefit or service that is less effective in affording equal opportunity to obtain the same result or gain the same benefit. So if the result or the benefit to be gained for emergency services is recovery or helping someone's condition to improve or at least not to progress, that should be the goal of most emergency response systems. So again, people in a physical crisis get more of a benefit from emergency response because they're able to get to the hospital on a rather quick basis, and they're able to get the help they need, and hopefully they can either recover or their situation doesn't get worse. For mental health crisis, they don't have that equal opportunity to gain the same benefit because an individual has to wait for so long. They don't have the same chance as recovery. So that's an unequal opportunity. And then discrimination is also aiding or perpetuating discrimination against a person with a disability. So basically, discrimination does not have to be overt or intentional discrimination. It doesn't have to be something as clear as people with disabilities don't get service X. It doesn't have to be that blatant. Anything that could cause discrimination, anything that perpetuates discrimination or fails to provide equal opportunity is considered discrimination under the ADA. So discrimination under the ADA also includes the failure to make reasonable modifications in policies, practices, or procedures when the modifications are necessary to avoid discrimination, unless a public entity can show that the modifications would fundamentally alter the nature of the service or program. So unless the reasonable modification would completely change the service being provided, that reasonable modification has to be provided. And it's basically, a reasonable modification is basically a change in how things would normally be done for someone without a disability. So some other types of discrimination, using methods of administration that either have the effect of discrimination or have the purpose or effect of defeating or substantially impairing accomplishment of the objectives of a program with respect to people with disabilities. So basically, for the emergency response system, we have a system that has the effect of discriminating against people with mental illness, because again, it's a two-tiered system. People without disabilities and people with physical disabilities get care much sooner to deal with physical health crises than people with mental illness get services to deal with a mental health crisis. So again, that has the effect of discriminating against those with mental illness. And the two-tiered system we have also substantially impairs the objectives of having an emergency response system. An emergency response system is meant to assist people when they are in danger, to make sure that they can either be provided the health care that they need or the assistance in providing for their safety. So that emergency response system, the objectives of that system are defeated or impaired for people with mental illness. So basically on their mental illness, they're not able to achieve the same objectives from the emergency response system as someone with a physical emergency. So discrimination in crisis response. So just some more information to try to apply the ADA to the crisis response system. So the state and local governments provide an unequal benefit by responding more quickly and safely to physical health crises in comparison to mental health crises. So again, that's an unequal benefit, and it's administering the system in a way that has a discriminatory effect. So again, crisis response systems are administered in a way in which the objective of crisis response is substantially impaired for persons with mental illness. So simply based upon their mental illness, the objectives of crisis response or emergency response is substantially impaired. And also the objectives of a quick and safe response to a crisis are mostly met for people in physical health crisis, but not for persons in a mental health crisis. So again, whether it's intentional or not, the current emergency response system we have prioritizes physical health crises over mental health crises, which has the effect of discriminating against people with mental illness. So, and then the lack of reasonable modifications is also an issue of discrimination within crisis response. So training law enforcement officers in mental health crisis intervention must be provided as a reasonable modification to policies to prevent discrimination against persons with mental illness. So that's, there may not be an existing policy in many departments to actually receive crisis intervention training or those types of training for mental health crises. They may only receive training on how to deal with someone in a physical crisis or someone who's being non-compliant. So the requirement to train officers in mental health crisis could be considered a reasonable modification that many departments fail to provide. And law enforcement agencies and officers must also utilize crisis intervention training they do receive to de-escalate mental health crises as a reasonable modification to the typical response to non-compliant individuals. So again, in Arizona, there are a number of law enforcement agencies, a number of police departments that do have training. They do have crisis intervention training. The training is provided, but it's still often not utilized by the agencies and the officers on the ground. It's one thing to receive training, but the training has to be used. And oftentimes, officers on the ground fail to provide that reasonable modification to use verbal de-escalation techniques that they have been trained on to try to de-escalate mental health crises. And they approach a person with mental illness as a typical non-compliant individual and use the physical tactics that they've been trained in to achieve compliance, which can often have tragic results, as we've seen from the statistics around fatal police encounters for people with mental illness. So the training being used is a required reasonable modification. And also, law enforcement should transfer persons in mental health crisis to treatment facilities as a reasonable modification to the policy of arresting a non-compliant individual. Again, providing a person with mental illness in a crisis with a reasonable modification instead of an arrest, which would typically be done with someone who's not compliant with lawful police orders. A person in a mental health crisis should be transferred to a treatment facility rather than a jail. And state or local crisis response systems can have the effect of discrimination by providing unequal services for physical and mental health crises. So even if it's unintentional, the effect of discrimination is there. People in a physical and mental health crisis receive unequal services. People in mental illness receive a lower quality service than an individual with a physical health crisis. And also, most state Medicaid programs, which Medicaid is the program that funds mental health services in most states. Most state Medicaid programs provide the full range of medically necessary physical health services while implementing an inadequate mental health services. So, a Medicaid provider, they may cover the entire range of all types of various physical illnesses that might occur, all the specialties in existence right now, multiple providers for each specialty. The same is not true for the mental health service system. There is a limited number of mental health clinics that will take Medicaid. insurance. There's a limited number of crisis response staff. It's just an inadequate system when you compare it to the physical healthcare system. So again, that has the effect of discrimination against people with mental illness. Now, I'm just going to discuss some ideas for reform. So there was a paper in 2020 that came out called Youth Mobile Response Services and Investment to Decriminalize Mental Health. And it was published in the Center for Law and Social Policy in their journal. So I have a link there to the paper if you'd like to read it in its entirety. And provide some recommendations and ideas for reform. And while it's geared more towards youth and diverting youth from the criminal justice system, some of the recommendations can be utilized for youth as well as adult systems. So some ideas for reform in this paper that I mentioned, make investments in a police-free mental health response. So that's the best thing that can be done. Take law enforcement and police out of mental health crisis response because they're not the most qualified to assist with it in the first place. Mental health crisis response should be handled by trained mental health providers. And then creating a unique point of entry for accessing global crisis intervention services. So creating a three-digit number like 988, a unique single point of entry for all mobile crisis intervention, but also making sure that single point of entry is backed up by a properly funded system. So it's not just enough to have that three-digit number. When someone calls that three-digit number, they should be connected to services immediately. Train all staff involved in mobile crisis intervention, including but not limited to dispatch teams and EMTs. So make sure the entire emergency response staff, everyone within that system are trained on mobile crisis intervention. Anyone who's going to be responding to a crisis call has adequate training. And that's all staff, not just certain individuals, but everyone who's going to be responding to that crisis. Do not require mental health responders to have professional degrees, but allow peer support specialists and community health workers to provide mobile crisis intervention. So it is important that these systems are obviously run by mental health professionals and individuals who have professional degrees. But peer support can play a very important role in assisting with mental health crisis, because peer support specialists are individuals who may have been through the same crisis themselves. They have lived experience. They're oftentimes the best individuals to respond, as well as community health workers, because they deal with the community, often low-income individuals, and they have a lot of experience assisting people with mental illness. So that's also very, very important. Okay.
We have one question. I'm sorry.
Okay.
And it's about building improved prevention and intervention crisis lines. So the question is that we always have the agencies in these conversations. How can we speak with the legislators and other responsible parties and invite them to help us understand the discriminations?
So as I mentioned, ACDL did sign on to a report. It was a collaboration with ACDL, the Arizona Developmental Disabilities Planning Council, and a number of other advocacy organizations, and we did issue a report. It was more focused on the crisis response for people with a dual diagnosis. So someone with developmental disability and mental illness. But we did issue that report, and one of our recommendations in that report was legislation. And we have asked the state legislature to schedule meetings with us, meetings to discuss this issue and talk about any possible legislation that can be done to deal with crisis. So it was on behalf of people with dual diagnoses, but it could help the crisis system in general and improve it for anyone who has a mental health crisis. So yeah, many of the fixes will take legislation. So it's important to contact state and federal legislators, state legislators and federal members of Congress, and to discuss this. And if you have a personal story, to tell your story, and just to try to get some movement on it in that way. And various organizations collaborating together can have an amplified voice. So that's also important, is that we collaborate with each other and try to amplify this issue and bring it to the attention of the public and the general public, as well as our policymakers. So I'd like to pause here and just provide the code word for continuing legal education. So this is only for lawyers who are seeking continuing legal education credits. So only for the lawyers who are attending today. The code word is crisis. So CRISIS, crisis. So you're going to email that code word to Christina Gutierrez. So her email is CGUTIEREZ@azdisabilitylaw.org. So if you're a lawyer today, attending today, and you want your continuing legal education credits, send the code word crisis to cgutierrez@azdisabilitylaw.org. And also to get your certificate, if you are seeking those credits, and your attorney seeking those credits, make sure you complete the survey at the end of the presentation. Okay, so we discussed some ideas for reforming the system. Now I'd like to talk about some progress that has been made, and a couple of other states that are doing things a little bit better and have made some progress on this issue. So the first example is Connecticut. So in Connecticut, mobile crisis teams are able to respond to 92% of mental health crisis calls in under 30 minutes. Now, more work to be done. Obviously, that should be 100%, but 92% is still that's a high number. 92% of mental health crisis calls responded to in under 30 minutes. That is important progress. In Arizona, it can be up to 2 hours. Connecticut can do it under 30 minutes. So we do know progress is possible. Connecticut also has a statewide mobile crisis intervention system that reaches all of its counties through contracts with 6 different clinics. So 6 different mental health providers have contracts to provide mobile crisis services. So in Arizona, it may need to be more than 6 because we are a larger state, but again, it is possible if you expand the available funding you can expand the number of mobile crisis providers and expand the amount of services that are available. And there's also a requirement in Connecticut that schools and community-based organizations collaborate with community mental health care providers to make mobile crisis available. So it brings schools and various community-based organizations into the conversation and make sure that they collaborate with mental health care providers. And this is also very important from the perspective of prevention. The schools and the community is where prevention starts. We can connect people to the services they need to prevent that future mental health crisis from even happening. So that's also very important. And then Oklahoma, one of the things Oklahoma has done well is that they've collaborated with the University of Oklahoma to design and implement a statewide evaluation tool to evaluate the availability and quality of mobile crisis intervention services. So they have partnered with the #1 research university in the state of Oklahoma to actually monitor and evaluate the quality of mobile crisis services. That's extremely important, and that's something that's often absent in Arizona and many other states, inadequate monitoring of the system. And also this provides independent oversight. So it's not a typical state agency, although funded by the state, not actually a state agency that's doing the monitoring. So that's also very important. And then Oregon is also has an example of some things some best practices that they're doing right. So mobile crisis teams in Oregon have access to police dispatch, allowing them to respond almost immediately to mental health calls. So if someone does not know how to reach crisis services directly, and they do end up calling 911, that police dispatch is already connected to the mobile crisis team. So there's a seamless transition where the 911 call comes in and it's immediately dispatched to a mobile crisis team because it has to do with mental health. And again, that takes adequate funding as well as training, both for police dispatch, for 911 operators, as well as for the mobile crisis teams. And then each mobile crisis team also consists of a nurse or EMT and a crisis worker with several years experience in mental health. So again, they have the requirement that they're going to hire the most qualified people. They're going to look for someone with several years experience to assist with these crisis situations. And then both medical and mental health members of mobile crisis teams receive extensive training, which only begins with up to 40 hours. So that's only the beginning. And it's up to 40 hours of classes on crisis intervention, de-escalation, harm reduction, and street medicine, which is basically medicine that can be provided to individuals living through homelessness and those types of issues. And then after the initial 40 hours, that 40 hours is before they even go out into the field. Once the team members are in the field, they receive an additional 500 training hours during the first 6 months in the field. So that amount of training, the scope of the training, as well as the amount and duration of the training, is something that Arizona and I think many states across the country could learn from. And even with all of that progress that I have mentioned, more work does need to be done. So just a few closing thoughts that I had. So adequate crisis response saves lives. We know that again from the statistics related to police violence and failed police encounters, that if there is an adequate crisis response, the police often don't even have to get involved and lives can be saved. And if the police do actually receive the training and implement the training received, that can also save lives. And mental health crisis, again, should not be the job of the police, but mental health professionals and peer support. And when faced with a mental health crisis, law enforcement needs adequate training and, again, adequate implementation of their training. You can receive all of the training, but if you're not using it, there's still an issue there. So that training needs to be implemented. And then state and local crisis systems need adequate funding. The only way there can be enough crisis response staff is if there's adequate funding. The only way we can hire the best, most qualified people for this work is if there's adequate funding. And post-crisis follow-up and notification of the individual's treatment team is almost never done. And that's also key. That's very important to prevent future crises, is making sure that after the crisis, the treatment team is notified and long-term services are put in place to prevent a future crisis. So some things that we can do. The big thing you can do is tell your story. If you've had a mental health crisis, or you have a family member who's had a mental health crisis, and you've had difficulty getting an adequate crisis response, tell that story. And, still unfortunately, mental health issues and mental illness can be stigmatized in our society, but it's important to destigmatize those issues and talk about them. The only way change can be made is if we talk about what the problems are and talk about solutions. And then contact policymakers regarding the issues and ideas for change. So some of the best practices in this presentation, some of the ideas for reform. Contact your local policymakers, whether it's your city council member, your mayor, your member of Congress, your state legislator. Contact the policymakers and make sure that your voice is heard and discuss these issues. And I'll tell you, especially on the state and local level, a lot of these policymakers and lawmakers are available. You can call the office and make an appointment and actually see the individual themselves. Not so much at the federal level, you may see a staffer, but at the same local level, often you can meet your own legislator or your own city council member. So it's important to contact those individuals and advocate for change. And then advocate for yourself. That even if you're in a crisis and you call for help and they're unwilling to help, or they're unwilling to send a mobile crisis team or any of that, it's important to try your best to be your own advocate. And even afterwards, even if you cannot do that when you yourself are in the midst of a crisis, even after the crisis abates, file complaints with if it's a Medicaid funded system, file grievances, do those things to advocate for yourself. And then advocate for others, even if it's a family member or even if it's someone you don't know that may have received inadequate response in the mental health crisis. It's important to advocate for others within our community, and then work collaboratively. So even if you're not professionally an advocate, volunteer for advocacy agencies, work with other agencies. If you are an advocate, if that is your profession, then seek out other agencies to work with. It's very important that we work on this issue as a community. And then the last thing I'll say is vote. That's very important, I think. Voting for individuals, voting for candidates who care about these issues, who care about mental health crisis response. Election for county prosecutor, or city prosecutor. A lot of those prosecutor positions are elected positions. Voting for prosecutors who care about this issue, voting for state and local leaders that care about this issue, will discuss this issue and devote enough time to it. So voting is extremely important. Okay, so that's the end of the slideshow. I'd be happy to answer any other questions. Feel free to either post a question in the chat or even just speak up with a question you may have.
Okay, thank you, Asim. And thank you so much for your very in-depth presentation. There are a few messages in the chat, so I'm going to start here. From Valerie. I am curious if any federal legislation has ever been considered that will enforce responding to a mental health crisis a priority, just like responding to someone in a health crisis. The information presented is sad and all states should be on the same page.
So there isn't legislation. I mean, there isn't federal law currently that would speak to that issue. I'm unsure if there is anything in the works. What I can tell you is that the American Rescue Plan Act that was passed early in 2021 did provide additional funding under the Medicaid program for states to expand home and community-based services. So under that, they could apply for additional funds for crisis. And there was actually also a dedicated pot of money specifically for mobile crisis services. Now, unfortunately, Arizona has not applied for any funding for additional crisis response. Arizona did receive funding. They did make a request for some of that home and community-based services money. But they're not going to be using any of that money for crisis services. So that's unfortunate. And they still have not applied for the other funding related to mobile crisis, which is also unfortunate. So again, if you do live in Arizona, I would encourage you to contact your state legislators and bring up this issue and ask that they do request that additional funding to fund more crisis staff as well as better crisis service.
Okay, thank you. And this one's slightly similar, but the SAMHSA report referenced in the chat talks about establishing a set of national guidelines for crisis care. Is there a national organization or structure that mandates uniform responses and standards of care? If not, how is that applied to individual professions such as doctors, nurses, police, first responders, etc.?
Well, so the SAMHSA guidelines are guidelines. They are federal guidelines. So often what SAMHSA suggests, or the guidance SAMHSA suggests, can oftentimes be considered a standard of care because it's based on their research of the current standard of care and what the best practices are. But it's not a mandate. SAMHSA is a very good resource for state as well as local crisis and emergency service providers to look for best practices. But I'm not aware of any mandates around what must be provided in a crisis system.
Okay. And we still have plenty of time. We've got a couple more minutes left for questions. So please either put your questions in the chat and I can read them aloud, or you can use the raise hand function at the bottom of your screen to the right, and we will call on you and you can ask your question verbally. And a question from Tasha. Tasha, if you want to unmute yourself.
Oh, can you hear me?
Yes, we can.
Yes.
Okay. When people are older, say if you had like psychiatric breaks when you were, if you're like a senior, are you more susceptible to it, or does like your brain heal?
For the interpreter, do you mind repeating that question? It was going a little bit in and out.
Okay, I'm sorry. Say for example, you have a psychiatric break when you're younger. When you're a senior, are you more susceptible to it? Because like when you get older, like your body breaks down and stuff.
I don't think actually, I'm sorry, but I don't think I can answer that. I think that's more of a medical question, so
Okay.
just not my area.
Okay, thank you.
Okay, thank you. And there is a from Dr. Applewhite that it is sad and unfortunate that I have been advocating for over 40 years and we're still dealing with the same issues. The key is collaborating and helping each other now. Thank you.
Yes, yeah, that's an important point. Again, collaborating within our community and reaching out to various different organizations and communities and working together, because this really is an issue that affects us all. We've seen all the tragic incidents of police violence and police shootings, in Arizona as well as across the country. And many of those individuals were dealing with a mental health crisis. So, yeah, this is definitely an important issue that we should all care about and really work together on.
Mr. Fowler. Oh, Mr. Fowler, if you mind waiting for a second, I'm going to go to Carla, then I'll come back to you. Carla Truman says, a challenge I face here in Arizona with DDD policy that requires a 30-day period of time for the release of the hours for a client with DDD SMI diagnosis when their current placement is unable to meet their needs. Does this possibly fall under ADA for unequal access? I have based my objection to their policy as it is there to protect dumping clients, not meant to enforce clients back to placements that are not working.
Okay, so I think I would need more information on actually what that policy is. But again, if it's something that specifically provides an unequal service because someone has a mental illness or a dual diagnosis, it could potentially be discrimination. Again, it doesn't have to be intentional. If it has the effect of discriminating on someone simply based on the diagnosis, yeah, that could be discriminatory.
Okay, thank you. And Mr. Fowler, I see your hand up.
Yes, Natalie, I looked at the chat and Dr. Applewhite had several questions about veterans and mental health. Are we doing anything in terms of veterans or what resources might be out there for veterans serving that system?
So, yeah, I'm not sure what specifically is available for veterans, but the Arizona crisis lines are open to anyone experiencing a mental health crisis, whether they're enrolled in the Medicaid system or not. The crisis lines are open to everyone. I'm sure that Dr. Applewhite has done this, but I think the VA probably would have more information on that.
Okay, thank you. Do we have any, we've got about 2 or 3 minutes left before we need to wrap up. So do we have any further questions? Or again, you can use your raise hand function or message us in the chat. Ms. Applewhite, you're welcome to raise your hand and we can open up your mic. Or Jeff, I don't know if you.
Should be okay now.
Okay.
Okay, thank you very much. This is Dr. Applewhite. I just want to say that I have been in meetings around the country, and every time that I mention the issue of veterans and suicide, I am always, and not necessarily ignored, but the conversation is discarded. And part of the reason is because most people are not familiar with the fact that there are underserved veterans with hidden disabilities. And there's a psychology of the veteran, as Ronaldo Wilder and others that have been to my workshops know that I've talked about the psychology of the veteran is not one to come forward and say that I have a mental health issue. So therefore, we have to go out and reach out in different ways. And so I've developed some outreach strategies, and I'm really looking for people to help me build a network that will support the ongoing networks that are here, and also a follow-up to make sure that those resources that we give people are actually being applied, implemented. Okay, so I just want to let everybody know that I'm trying to build this network. I have helped with Ronaldo and David, and just appreciate all of you for what you're doing today. And so, you know, help this old professor out. I'm a retired old professor, not too old though. I'm still looking good though. Okay, but listen, please, I hope that I hear from some of you. Thank you. Great conference, Asim.
Thank you, and thank you so much for your comment and all the work you're doing.
Thank you.
Okay, well, I want to thank everybody. Thank you, Dr. Applewhite, for Asim, for your presentation today. I did put in the chat. If you have any questions about today's session or further previous or future sessions, please email me. I put it in the chat, nlunarose@azdisabilitylaw.org. Please fill out the survey that the link was just put into the chat. Complete the survey to receive your certificate of attendance. And I also would like to thank our interpreters, Joshua and Aliki, and our captioner, Sabrina, for all their work today. And then also to all our sponsors. I have put in the chat as well. So if there are not any further questions, please, our next session will be Thursday at 9 a.m. And that session will be on vaccines. Vaccine misinformation, impact on misinformation on the African American community, Doctors Danielle Gilliam and Dr. Tanya Henry, and that should be a very lively session. So we hope to see you then, and please register for further sessions, and I wish everybody a good afternoon.